As we saw here, the narrow complex can be atrial in a region, or it can be atrioventricular in a region, but this basically means this is above the ventricle. The origin is above the ventricle, which is also can be called supraventricular, but I'll explain because this can cause some confusion. I'll explain in a second. So the impulse generation is from the atria, or from around the atrioventricular area, or from around the AV node. So the atrial arrhythmias can be again regular or irregular. Now we'll just focus on the most common ones. So of course the most common arrhythmia is actually a sign. It's not truly an arrhythmia, but it's a, as we all know, this is a reactionary thing which the body does, for example in reaction to pain, infection, etc. Now we can develop something called atrial tachycardia. So focal atrial tachycardia means there is a focus in the atria which is excessively firing above and beyond the SA nodes firing rate, and then it takes over the system, and we develop tachycardias. But the more common one is atrial flutter. Now atrial flutter is a macro reentrant atrial tachycardia, which basically means that there is a re-entry circuit which has developed throughout the atria. So there is an impulse that is going round and round. So some of these impulses would be traveling down, and then we will get a tachycardia. This is an extremely important concept to know. Normal SA node goes into the AV node and then goes down into the bundle of his, and then the right and the left. So AV node, this is a very important, physiologically important area, because this has got a very protective, very important physiologically and clinically important protective function. AV node serves as a filter. It will filter impulses from that pass between the atria and the ventricle. For example, if we've got a pathology in the atria and the impulses are being generated at around say 300 beats 300 per minute in the atria, if the AV node allows all of these to pass into the ventricle, then the ventricle will be beating at 300 beats per minute, which would basically mean there would not be a good sufficient cardiac output, and we would the patient would be going into cardiac arrest most likely. So the AV node does not let all these impulses pass down, and it filters. For example, if it lets half of these, if it filters and blocks half of these impulses and only lets half of them to pass through, then in the ventricles would be beating at 150 beats per minute. And this basically this is still better than the 300, of course, because there would be some significant cardiac output, and of course the patient would have a tachyarrhythmia. So the normal dimensions and the properties of atria is such that if a macro re-entry circuit develops in here, then the impulses that are generated in the atria, they are actually 300 per minute. This is because of the normal dimensions and the normal properties of the atria. So if a macro re-entry circuit develops throughout both right and left atria, this would translate into an atrial activity of 300 beats per minute. Now, as we can see, the important function of the AV node is to block some of these impulses. So if it's healthy, for example, and if it's blocking half of them, only it will allow 150 to travel down. This is actually one of the most common presentations of atrial flutter. As the name suggests, the atria are fluttering, and they usually flutter around 300 atrial activities per minute. And if it blocks half of these impulses, so this means if for every 2 impulses it is only letting 1 impulse to go down, it would translate into a ventricular heart rate of 150. So this is one of the most common atrial flutter presentations. So when we say 2 to 1 block, this is what we mean. And on the ECG, we will see, instead of the P waves, of course, this time we will see what are called the flutter waves. The sawtooth pattern that they say. This is because of this macro re-entry pathway that has developed and is causing the sawtooth pattern. And of course, when you will see QRS complexes in between. So if we complicate things a little bit more, so suppose this patient has also got this accessory pathway. So if this is a patient with Wolff-Parkinson-White syndrome. Now the impulses that are fluttering in the atria, they have got two choices. Either they can travel down from the AV node or they can go down from this accessory pathway. AV node is good in the sense that it will filter these impulses, but of course this accessory pathway lacks this filtering property, so we would prefer the impulses going from the AV node instead of the of this accessory bundle. If this patient is given AV nodal blocking agents, for example verapamil, diltiazem, which are calcium channel blockers, or adenosine, so this will block the AV node, and now all the impulses will travel down from the accessory bundle. This is very dangerous because suppose now there are 300 activities per minute going on in the atria, and they would all go down from the atria to the ventricle, and this will actually cause again no cardiac output or cardiac arrest, or this will actually go into VT or VF and the patient can collapse. So this is very important that patients with Wolff-Parkinson-White syndrome who have got atrial fibrillation or atrial flutter, that they should not be given AV nodal blocking agents, because giving them these agents can convert these rhythms into VT, VF. So this is very important. So because this can happen in atrial flutter or atrial fibrillation, because again in atrial fibrillation there are multiple focuses that are firing rapidly in the atria, and the rate is more than basically it can go around 250 to 300 or things like that. So if all these impulses go down from this bundle, then this will again translate into the same thing. So any patient who's having lots of activities in the supraventricular region, that is AF or atrial flutter, who has got Wolff-Parkinson-White, this accessory pathway, then they should not be given AV nodal blocking agent. This is the bottom line basically. Atrial tachyarrhythmia, so sinus tachyarrhythmia or atrial flutter, these are the two most important ones. Irregular, most common as we all know, is atrial fibrillation, and there are some other arrhythmias as well, but we won't be going into details of them at the moment. Now, as we said, the narrow complexes could either be atrial or they can originate from the atrioventricular region. So atrioventricular region, these can be in the form of AVRT or AVNRT. These are the two most important ones, and these are actually as a group called the SVTs. When we hear the term the supraventricular tachycardias or the SVTs, these are the ones that are meant. But this can be a bit of a misnomer again, as we said, because of course the sinus tachycardia is also supraventricular, the atrial fibrillation is also supraventricular, and the atrial flutter is supraventricular. So the cardiologists usually prefer using these terms as AVRT or AVNRT instead of SVTs. These are very simple, but they can seem very complicated and very difficult to understand. AVRT basically means atrioventricular re-entry tachycardia. So basically we have got a re-entry pathway which involves the atria and the ventricle, and the example of that again is this happens only in patients who have got Wolff-Parkinson-White. So what happens is the impulse goes down from the atria. So suppose it goes down from here, and then it goes down from here, and then it goes up here, and through this pathway it can transmit here back into the re-enter into the atria from the ventricle, and then this can develop a circle, and this can go on and on. So this is basically atrioventricular re-entry tachycardia, a heart rate more than 100. This is what is meant. So this happens only in patients with Wolff-Parkinson White syndrome, and this is one of the most common arrhythmia that is seen in Wolff-Parkinson White syndrome. The other is AVNRT. So AVNRT basically means that there is a atrioventricular nodal, so AV nodal re-entry. So basically there is a re-entry pathway which is in or around the AV node. So the impulses are circling around inside or around the AV node, and then because of this circuit the impulses keep going down and we get the tachycardia. So AVRT and AVNRT are were traditionally called the SVTs, and they on an ECG they appear similar mm, uh, because of when they appear as narrow complex tachycardias, and they're identical on the ECG. The reason being the ventricles actually, as we said, are being depolarized from the normal pathway, so they would be narrow, and they are regular because of the re-entry. So all the re-entry ones actually mostly give rise to the irregular complex tachycardias. So the ventricular tachycardias are the first group of the broad complex tachycardias, and as you all know, they are VTs or VFs, and the VT can be regular, or if it can be irregular if it's polymorphic VT, which is also called TDP. So to summarize, this is the slide that we all need to understand and know to differentiate all those arrhythmias. So number one, the arrhythmias can be narrow complex or they can be broad complex. So in the narrow complex, they can be regular or can be irregular. In regular, the most common ones are the sinus tachycardia, where there would be a P wave, and the atrial tachycardias. So either the tachycardia is originating from the SA node or from the atria, or they are originating around the AV node, or using the accessory pathway. So 1, 2, 3, and 4. The sinus tachycardias, atrial tachycardias, more important of which is atrial flutter, and the re-entry tachycardias, which is AVNRT or AVRT, the SVTs. Irregular, of course, the most common one is atrial fibrillation. Is a very important one as well. And in the broad complex tachycardias, again, either they can be irregular, which is VT, or they can be all these causes of regular narrow complex tachycardias with the bundle branch block or an accessory pathway, or they could be irregular, which could be polymorphic VT or toss TDP, and or it can be the any cause of irregular narrow complex tachycardias with bundle branch block or aberrancy, as we discussed, which is basically AF with bundle branch block or accessory pathway. This basically gives you an idea of what the rhythm is from the exact rate. The flutter, see here it says 150, so this was the point which I was trying to highlight. So 300 is the number of activities going on in the atria in flutter, and if it's 2 to 1 block, so for every 2 impulses 1 is allowed to pass, it translates into 150 of the ventricle. And in the SVTs, or actually we should say the AVRTs or AVNRT, the rate is around 160 to 170. I won't go into detail of this, but this is a nice chart to basically differentiate between all those narrow complex tachycardias, and it takes you step by step if depending on the P waves and morphology and the PR ratio.